as a way to review what we covered today and also remind ourselves or how to actually we can use for our research. So we're going to, I'm going to introduce some case study that I did. Really, this is case study that I did just to learn Part D data. It was around 2008 or 9. Part D data just came in. Only what we had was 2007 data. So we wanted to learn data. The best way to learn data is what to do study, right? So if you really want to write a paper, then actually you can learn about the data because you have to learn data, right? So this is the manuscript that I wrote as a way to learn our party data. So as a background, so we discussed that the Part D program is somewhat unique in the Medicare because every beneficiary has to enroll in the private plans to receive Medicare Part D benefits. So well, we've been singing MAPD versus standalone PDPs all day long, right? And we know that, yes, standalone PDPs for traditional people service, beneficiaries, those who stay in the traditional Medicare program, and MAPDs that they chose Part C, right, or Medicare Advantage or managed care plans, and MA plans are required, except very small some exceptions. They are required to provide Part D services, and that they are in MAPDs. So we are comparing these two types of plans. Well, what is the real difference between these two types of plans? And of course, we see a lot of differences in benefit schemes or premiums or service areas. There will be differences, but really you could say one difference is, but to me, the one critical difference between these two different types of plans is that MAPDs as a one insurance company or one insurer, they cover both pharmacy services and medical services. Here, medical services are Part A and B services, right? Oh, however, but standalone PDPs, they cover only prescription drugs. That was, to me, it's really important, and it's somewhat something interesting differences between these two types. And so why? And why does it matter? Right? And one covers two different types of services, and then PDP, standard PDPs covers only part of prescription drugs. Okay, so we know that literature has shown that the increased medication use, or you could simply say the increased medication adherence, right? So why do we want to actually promote improving medication adherence? Because when you have better medication adherence, they actually down the road, those patients tend to have fewer hospitalizations and less use of emergency rooms. Oh, okay. So then what does this mean? What we have two different types of services. They might be they are potentially substitutable, which means that when you use one service more, you can reduce use of the other type of services, right? So then on some discussion says that, well, when there are two different types or some even more three types or some different types of services that are substitutable. Now, by using one type of service, when you reduce the other type of services, it's better. You can achieve optimal level of medication use when those types of services are provided by one insurance, right? Why is that? Because these plans, let me see, right? Right. So, okay, here. Why? So MAPDs, right? But they offer coverage for both the pharmacy and medical services. Then they have incentive to improve, to encourage their enrollees to use more medication or to adhere to the scheduled medication use, right? And why? Because they can potentially expect the cost offsetting effect, which means that down the road, they may actually have savings from a medical side, Part A and B side. Oh, okay, it's okay to be used a little bit more on Part D spending. However, we can actually save maybe more in A and B side. Do standalone PDPs have that type of incentive? No, if they encourage their enrollees to use more medication, that's their cost because they don't provide the Part A and B services, right? So traditional Medicare, people service side can save some money but they're going to spend more. It's more costly to them, right? When they increase, when their enrollees increase their medication use. They may be standalone PDPs may not have incentive to actually improve some medication adherence, because if their enrollees don't adhere to medication, that if there is more hospitalization and ED visits, that cost goes to the traditional Medicare fee-for-service side. Then the hypothesis or the question that we could ask is that, oh, is there any difference in medication adherence between these two types of Part D plans, right? And so we wanted to compare statin adherence among beneficiaries in MAPDs and PDPs. Now, question here is, what is your hypothesis here? So here I said that this means that I hypothesized that statin adherence would be higher among MAPDs compared compared with PDPs, right? So let's see what you find here. We focused on statin use because the statin belongs to anti-hyperlipidemics, right? When you have a high lipid level in your blood, that's hyperlipidemia, then that anti-hyperlipidemia, that therapeutic class has the highest amount of reimbursement in Part D program. And among these anti-hyperlipidemia, statin is really dominant drugs. And also we have literature that shows that low level of statin adherence can increase utilization expenditure for non-drug medical services, such as through hospitalization or AD visits. So MAPDs may actually encourage their enrollees to improve statin adherence in order to reduce total medical costs in A and B side. All right. Now, so I defined, so now this is a question for you. You can unmute yourself for a second and answer the question, or you can just type in. Right, so this is my study question. I already explained the background, right? So we want to compare MAPD and PDPs and statin adherence. How would you define your study population to address this research question? Any volunteer who wants to answer? Can you repeat the question again? Okay, so what is the study question here? So study objective here is we're going to study. Oh, yeah, somebody answered. Yeah, we're going to compare statin adherence between MAPD and PDPs. And in order to answer this question, how would you actually go about? How would you define your study sample? That was the question. Right, and somebody answered here. Green says that population that has had at least one fill of a statin in the year. Yes, so that's what we did. You could have selected those who have hyperlipidemia, etc. But then you need to use A and B claims data, which I didn't have back then. Right, so I had only Part D data, but I wanted to get the statin adherence, so I defined as Medicare beneficiaries who filled at least one prescription for statin in 2007. That was my study population. And of course, it's a usual exclusion or inclusion criterion. I limited to the older adults, and also those who have both A and B coverage, and I excluded ESRD, and also I limited it to non-LIS population, because the way I saw it was that how could then MAPD plans improve statin adherence among their populations by providing more generous drug benefits? But LIS population, whether you are in MAPDs or PDPs, that they have a very small cost sharing. It doesn't really distinguish. The cost sharing is not different between these two types of plans. So I limited it to non-LIS. Statin adherence require at least 2 or more fills. I'm not quite sure. You might have not been able to. No, I'm not sure. Yeah. Koshik, I think we could, if the person has only one fill, that's and 30 days, but you are following up for let's say 300 days, then still your MPR is 30 divided by 300, right? Okay, so now, so we have identified that this our study population this way, and we are going to measure MPR, medication adherence. What data sets do we need? Just type in. So data sources. So this is your whatever the study that you want to do. You want to put up DUA, the data request. What data sets would you request? What do we need? PD event file, of course, yes. PDE, MBSF for sure, yes. PDE, MBSF, yes, very nice. Yeah. That's the main data sets, right? So we had 2007 PDE files for 5%. That's it. Yes, right. Well, don't forget the plan characteristics file. Okay, thank you. Somebody answered the plan characteristics file because we want to ensure that the MAPD versus PDPs, and also I want to use some benefit information as well there. And then here, I did actually had a med span just to identify statins, but not necessary to do this study these days, right? And also we had some area or the county level or zip level information from other public data source, right? Medispan, that's cheating. Why is it cheating? Somebody says that using Medispan data, that's cheating. Okay, I will tell you why. Okay, no, I can tell you. So in 2007, when we first started, there was no generic or brand name variables in PDE data. They were added later years. So PDE data has improved, and we had no information how to identify. So I used Medispan. Yes, right. But that's what I'm saying. If you were doing this study, you could simply identify statins based on generic names. There are only a dozen of statins, right? So construction of analytic file, how do you start? What's the first step? Inclusion doesn't require the beneficiaries to have both A and B coverage. Negate hypothesis, MAPDs have incentives to improve health, reduce cost of this they manage. That's exactly why. For Daniel, if you can speak up, if you want to elaborate. Yeah, I'm not quite sure. That's exactly what we want to test here.
So, okay, so the part A and B wouldn't necessarily be in fee for service, so they would be managed care as well?
Oh, yes, MAPDs they are receiving A and B services through their managed care plans, per se.
I see. Okay. Sorry, I was just confused by the language because I assumed that they would be in part C.
Part C, yes, it is
yeah.
Part C. Yes, Part C is MA.
Okay, so for the MA ones, they would be in part C, and then for the fee for service, they would be in part A and B.
Part C covers Part A and B services.
Okay.
For MA enrollees. And for traditional Medicare, we just simply say A and B, but for the people service population. But for Part C enrollees, Part C covers A and B services.
Okay, thank you.
Right. MedSpan is very costly. I know that's a side story, but call them and tell that if you are from academia, you might get a little bit better rate. I've been using medicine for a while in a very reasonable cost as an academician, right? Okay, so now how would you construct analytic files? So you have now PDE data and MBSF and then plan characteristics file. We defined our sample. We know what to measure, our outcomes, and we have study aims. What's the first step? What would be the first step? There is no the correct flow here. Usually, I would recommend that. Yes, exactly. We have to identify population, but oftentimes we would want to begin with MBSF, and you can actually select all this, the coverage restrictions or whatever you want to impose, age restrictions or excluding ASID, you can do that. And also if you have specific conditions, if your study population is a diabetes, then you have to go to A and B data and then identify patients with diabetes. Here, what is the study population here? And to those who use the statin, right? So identify MAPD versus PD plan which many. Exactly. So because here we defined our study sample as those who use the statins. Sorry, excuse me. We have to use the PDE first, right? And then using PDE data, we're going to actually identify patients who are on statin. Yes, correct. Then before that, yes, Grace says that, yes, statin medications, right? Where we have to first identify product service ID or in some way that what are statins, right? Okay, so we use the here we actually began with the Medspan data. And in Medspan file, they have a therapeutic class code, and these are statins that's starting with the 39, and then they identified all the NDCs. And from Medspan file, we actually get the generic name as well. So these are step now. These days, if you are requesting PD data now, you can do this using generic names of statins. We simply didn't have a generic name back then in PDE file. Next step is identifying statin users among Part D enrollees. So we linked this Medspan data to PDE records by NDC. And from PDE file, we kept only variables that we need. So what variables do we need? Of course, we need the Benny ID and contract ID and plan ID and product service ID. Do you remember these three variables that we need to create medication utilization measures, product service ID, date, and data supply. And also I kept the benefit phase because I want to control for those who hit donut hole in 2007. I thought that that variable would have a negative effect on medication adherence. And then next step, once we identify these statin users, we began to apply sample selection criteria, right? So this sample selection is based on the demographic characteristics, which are in MBSF, right? So from the back then it used to be called the BSF. So it's beneficiary summary file. We got variables age, gender, race, and B enrollment, LIS status, ESRD status, and zip code in order to link to any census or other ACS data. And then using this information, we excluded non-elderly LIS and ESRD Part B only enrollees. And then we began to add or construct covariates. Here, question here. So the key variable here is usually key covariate that you want, control variable that you want to actually use in the model is health risk variables, right? So again, remember, I didn't have any A and B claims. If you have A and B claims or all the MBSF chronic condition file, well, that's available only for people service, then you could come up with some different measures, even Charlson, if you have a diagnosis information or ITC, it's something that you could do. But if you have only PDE data, how are you going to control for health risk? Right? So this is probably the one that came out actually earlier in the morning that, okay, wow. So I do those who are on more prescription drugs, they are sicker, right? I mean, that's indicated. That's the way we do in the Charlson or something, right? The more diagnosis or the more serious conditions you have, you are sick, right? So I wanted to get the number of prescription drugs taken here. How do you define prescription drugs? Back then, we didn't even have the generic or brand name variables. And should I have counted the number of NDCs? In other words, product service IDs? That's too much, right? Once they actually switch manufacturers or, the packaging, then you're going to count to, it's just the number will go up, right? So this is really limited to PDE record, but we had Medspan data. So I used the prescription drugs as a therapeutic class. So I don't care whether you switch it from one hypertension drugs to another anti-hypertension drugs. To me, that's one. That means that you have a hypertension. If you have two different types of anti-diabetic drugs, I don't care. That means that as long as you use at least one anti-diabetics, that means that you have diabetes, right? So that's why I use the number of a therapeutic class. That patient took. And that was my health risk measures that I constructed only using PDE data. Of course, that was possible because I had MedSpan data. And also this you can ignore. It is back then there was a part of a contract. We got some early remote risk scores, but not important. And then we had other social economic variables from census files, or I might have used either zip code or county level. I don't remember. And you could actually add more alpha variables, or alpha is area resource file variables, or the American Community Service survey file, ACS variables. You can add those things. And then also from plan characteristics file, I identified the MAPD versus PDPs, and then what's their benefit package, whether they were in basic plan, the benefit package, or enhanced the benefit package, or the plan provided some coverage for the initial coverage gap. And that's the covariates that I used. So this is just shows the flow of constructing analytic files using graphs. And our outcome measure was MPR. This is a medication adherence. So I defined my MPR measure as the denominator is a number of days between first prescription date in 2007 through December 31st, 2007. Remember, I had only 2007 PD data. That's all the data that I had. Okay, so I just went with this definition. And then in the numerator, I summed up all the days of supply in 2007. But because we already saw the oversupply issues, so I constructed two measures. This is a continuous variable, MPR measure, and then I constructed a binary indicator that represented good adherence, where I defined MPR is greater than 80%. Okay, so this shows how we calculated the MPR. So this beneficiary, the first field date was March 4th, and here from March 4th through the December 31st, 2007, and then you can count the number of days in between these two periods. As this way, you should have it at 1, and then in the numerator you sum up all these days of supply, 60, 30, 60, 60. But from the last field here, some portion was carried over to 2008, right? So I wanted to subtract this portion. And this is adjustment of days that were actually moved to the, 2008. And that was, this is MPR measure for this beneficiary. This is the example. There is one question asking that how did I determine 80% as a good adherence? It's based on literature. It's very tricky. It sounds like arbitrary, but for statins, you can find some clinical evidence that shows the MPR is greater than 80% for statin use. They tend to have better health outcomes in terms of reducing hospitalization, etc. So that's statins. I had some clinical evidence. For other types of medications, you have to be careful. I would not simply take 80. If I would look for some more other clinical evidence. That was a good question. And then analysis, because we know that MAPD and PDPs, there are always some selection issues here. We didn't have a good instrument then, so we simply used propensity score matching. But it was a very strict one-to-one nearest neighbor matching just to ensure similar distribution in observed characteristics between MAPDs and PDPs. And then we estimated the probability of enrolling in MAPD using all the covariates available with us. Right, so this was a one-to-one matching with the nearest neighbor with a caliper of 0.01, and then we assessed whether the matching was performed properly using the standardized differences. And this measure, if values are less than 10, that usually indicates a good balance, right? So, and here, this is distribution. This is a full sample is a before matching, and this is after matching. Can you see this is huge? These differences in characteristics are somewhat striking. You probably may not get to see these huge differences these days because now MA enrollment is about over 50%. Half of Medicare beneficiaries are in MA, the Part C, and half of them are in traditional Medicare. So it's the difference is actually better than now. But this is a 2007 data when only probably 15 to 20% of MA, the Medicare beneficiaries were in MA. So before matching, you can see huge differences here in terms of a race or region or some variables here where how many actually, what percent of a patient actually reached a donut for it's 20% versus 31%, but after matching, it's very a tight matching, we actually achieved some balance between the two types of plans. So this is probably, but before matching, unadjusted, we just get this descriptive data. So before matching, it looked almost the same. NPR's MAPD was a 7.57, and this is 7.54 in PDPs. And then match the sample that this was MAPD 7.8, and then PDPs 9.4. Difference is 1.36 percentage point. And this was statistically significant. I will come back to this number. 1.36 difference in NPR is a really significant. What does that mean? Now, in the next, the second outcome, so this is a percent of beneficiaries with good adherence. NPR is greater than 80. In unadjusted mother, about 46% or 47%. It's almost the same between these two groups. In the matched sample, slightly higher in MAPD, 47%, and PDPs is 45%. Again, this is maximum 2 percentage point difference, and statistically significant. So the conclusion or discussion. So we found a significant, but the differences in statin adherence between MAPD and PDPs. However, the difference was very small, and we didn't think that this was clinically meaningful. NPR 70 versus 69 or 68, and it doesn't make any difference. So our conclusion was that our finding did not really provide a strong support for our hypothesis. And another striking one, this is 2007, it's not 2024, and the good adherence, the proportion of beneficiaries with a good adherence was less than 50% in both the groups. And this is too low, and I think it has improved over time. So we discussed that there was much room for improvement in both types of plans, and in Medicare populations, whether they are in MAPDs or PDPs. And limitations, of course, there are some unmeasured characteristics influencing statin adherence. It's really 1 year, the short time window. We didn't follow long term, and we didn't examine any switching. This should not be much an issue though, and the results cannot be generalized to other therapeutic class. And we didn't account for hospitalizations. And I don't know, I'm going to be really brief, just a few minutes, and why this, we find that this is, no strong support for our hypothesis, clinically negligible differences there. One possibility is, I think this first bullet point explains a lot. Both the MAPDs and PDPs contract out the same PBMs. So PBMs are pharmacy benefit management. So these PBMs actually do a lot of things to manage drug utilization. So they want to steer their beneficiaries to take certain types of drugs, and they might do some interventions, and they design benefits, and they actually set co-payment, and then when they actually implement intervention, these PBMs actually might not distinguish whether this is MAPDs or PDPs. They just do the same intervention to all types of plans that they serve. The PBM markets are pretty much concentrated, which means that we do not have many PBMs competing in the market. It's very a couple of dozens of players in the nation in the market. So which means that these MAPDs and PDPs have the same contract. They are using same PBMs. So that's why we might not see huge differences between this in our study. Another potential reason is that maybe why people are taking statins might be different. So for example, if MAPD enrollees have used statins for primary prevention, which means that you do not really have a cardiovascular events. However, just to prevent, right? So without prior cardiovascular disease, but just the prevention purposes, you might have taken the statins. For those cases, usually the adherence is lower, so maybe a larger proportion of MAPDs compared with the PDP enrollees, and they might have used the statins as a primary prevention. Then if we had selected those who used for those who had a cardiovascular disease, the difference might have been different, a little bit larger. We didn't have A and B data, so we couldn't really narrow down our sample to those who have cardiovascular disease. One possibility for using only PDE data, this one way to you can check this one is selecting beneficiaries who also took beta blockers or some other types of cardiovascular condition related medications. You could have done that, but we didn't and do this in this study.